In this session, we will be discussing about introduction to stretching and flexibility. Flexibility, according to Zakrzewski, flexibility is defined as ability of the muscle to lengthen, allowing one joint or more than one joint in a series to move through a range of motion. According to Holland in 1968, flexibility is characterized by ability of the muscle to relax and yield a stretch force, and also the range of motion available in a joint or a group of joints. From this definition, we can understand that flexibility of a muscle is mainly it allows the muscle to move through its range of motion completely. According to Holt, 1996, flexibility is the intrinsic property of the body tissue which determines the range of motion achievable without injury at joint or a group of joints. So, Holt, he gives importance that flexibility is the range of motion available, but it should be without injury. Another definition for flexibility is that flexibility is the ability to move a single joint or a series of joints smoothly and easily through an unrestricted pain-free range of motion. Now, there are two types of flexibility. These are dynamic flexibility and static flexibility. Now, what is the difference between dynamic flexibility and static flexibility? There are two types of flexibilities available. The first one is static flexibility and the second one is dynamic flexibility. By the name itself, we can understand. Dynamic flexibility is the flexibility during movement, and static flexibility is the static flexibility while at any joint without doing any activity, if we are not doing any activity. So, dynamic flexibility is the ability to attain a maximum range of motion of the joint while performing movements. This is the flexibility exhibited by while walking, running or participating in a physical activity. Now, the next type of flexibility is the static flexibility. Static flexibility is the linear or angular measurement of actual range of motion in a joint or a complex of joints. So, static flexibility, again it may be an active flexibility or a passive flexibility. Usually an passive flexibility is more when compared to active flexibility. Now, which are the things what determines flexibility? The first thing is that first factor which determines flexibility is the joint structure. That is, joints vary in direction and range of motion. Once we compare different joints, you see the shoulder joint, it is more movement will be available. Once you go to the knee joint, less movement is available. So, what is the position? What is the orientation of the joint? What is the position of the joint? It's joint capsule. How much tight the joint capsule, and how much stability gives the joint capsule give. These are the first factor which determines the flexibility. So, structure of the joint and joint capsule. Joint capsule these are semi-elastic structures that gives the joint strength and stability and limit the movement. So, a joint which is having a tight joint capsule will be having less flexibility. A joint which is having more that is loose joint capsule, so it will be having more flexibility. The second factor which determines flexibility is the muscle's elasticity and length. There are different types of structures, fibers which is present in the muscle. These are collagen, elastin, titin, etc. Now, there is collagen fibers are there. These are white fibers. These are the which provide structure and support. There are elastin fibers. These are yellow fibers. These are elastic and flexible. And titin, these are the filaments with elastic properties. Depends upon how much percentage of these fibers are there. Again, the elasticity changes. Then muscle length. How much is the length of the muscle? This also contribute to the flexibility. Next is bone structure. That is depends upon what type of bone, what type of joint it is. What type of joint. Consider shoulder joint and knee joint. Shoulder joint is more mobile than knee joint. It is due to the difference in the bone structure. Next factor which determine flexibility is elasticity of the skin. That is, elastic skin. If the skin is much elastic, flexibility will be more. Next factor which determine flexibility is the gender. It has been proved that women are more flexible than men. Next factor which determine flexibility is the age. So young kids, the kids are more flexible than older individuals. That is, as the age increases, the flexibility keeps on decreasing. So it's having a negative relationship with the age and flexibility. There is a negative relationship can be seen. Then next is the physical activity. As if the person is doing, what type of physical activity is doing depends upon the flexibility varies. A person who is doing a lots of stretching exercise regularly, he will be more flexible. But once a person is doing, it has been proved that if a person doing a weight training exercise more and is having a bulk of muscle mass, flexibility will be less in that cases. So physical activity, if he is doing, what type of physical activity he is doing, and the flexibility varies. Now aging, it decreases the joint range of motion. So again, as age increases, flexibility decreases. Now what are the benefits of this flexibility? Usually stretching exercise is used to be done to improve the flexibility. What are the benefits of flexibility? The first and the most important thing is that it prevents and decreases the incidence of injury. There are lots of studies have done in this matter regarding the relationship between flexibility and incidence of injury. Actually, the muscles work as a shock absorbing mechanism, like a shock absorber in a car. How it works, almost same type of work will be done by the muscles, and it absorbs the shock. The muscle shock absorbs the shock and decreases the chance of injury. Lots of studies have done among the different types of players, and a person who is having flexibility will be having less chance of injury, and less flexible people will be having more chance of injury. So there is a negative correlation between the flexibility, and there is a positive correlation between flexibility and lack of injury. So as the flexibility decreases, there will be more chance of injury. Next one is enhanced muscle performance. Again, lots of studies, n number of studies have been done regarding the muscle performance and flexibility. As the flexibility increases, there will be a better functional performance, better performance. So it is postulated that all the players should do the proper stretching and flexibility exercise, so that there will be better performance. Now the next is reduction of post-exercise muscle soreness, known as delayed onset muscle soreness or DOMS. So usually just after, there are two types of muscle soreness can be seen. One type of muscle soreness is just after exercise. It is almost like a myocardial infarction where it occurs. That is, it is just a type of ischemia where the blood supply to the muscle will be less, or that won't be enough, which is causing a soreness. This is acute soreness seen just after an exercise. But there are some type of soreness which starts after one day, that is after 24 hours of exercise, and it keep on decreasing till 48th hour. From 48th hour it keeps on decreasing. So 24th hour the pain starts after exercise, after a strenuous activity, and the pain keeps on increasing till 48th hour, and 48th hour onwards it keeps on decreasing, and it subsides by 72 hours. So this type of muscle soreness is called delayed onset muscle soreness or DOMS, and it has been proved that if the person is having enough flexibility, if he is including the stretching exercise during warm up and regular exercise, there is less chance of flexibility, less chance of delayed onset muscle soreness in these type of peoples. Now, it improves the body position and strength for sports. Now, enough flexibility is important. The proper flexibility is important for good posture and balance. So, if there is any decrease in the flexibility, there will be chance of changes in the posture, chances of decrease, there is some changes in the balance. So, proper good posture and a proper balance, flexibility is very much important. Now, once we tell about flexibility, once we discuss about the flexibility and mobility of a muscle or a joint, there are two terms it usually comes to our mind. These are hypermobility and hypomobility. What is hypermobility? What is hypomobility? Hypomobility refers a decrease in mobility or a restricted motion. If the joint or a muscle, there is a decrease in motion or a restricted motion, we can call it as hypomobility. Then what is hypermobility? By the name itself, we can understand that hypermobility is the increased range of motion. That is, if the range of motion is beyond the limit or beyond the normal, it is considered as hypermobility. Now, which are the factors which causes restriction of motion? Which are the factors which causes hypomobility? It may be the first and the most important cause for decreased, that is restricted motion, is prolonged immobilization. The causes for prolonged immobilization may be different. It may be an extrinsic cause or an intrinsic cause. For example, a person who is after a fracture, after a osteotomy, or after any repair or surgery, he is in plaster cast, or is in splint, or is in a skeletal traction after these procedures, or after a fracture, after reduction of fracture. This type of extrinsic factors are there which causes restriction of motion. So, prolonged immobilization causes a restriction of motion. The causes of prolonged immobilization may be an extrinsic factor or an intrinsic factor. Extrinsic factor means outside from the body. That is, after a fracture, after a osteotomy, after any trauma, after any injury, after reduction, or after along with the treatment, you are putting a plaster cast, or you are putting a splint, or you are putting a traction. This causes a prolonged immobilization and later leads to a restricted motion. The factors which causing the prolonged immobilization may be an intrinsic factor. The first intrinsic factor is the pain itself. For example, if there is any degenerative disease like osteoarthritis or any microtrauma or any trauma to the joint, so because of the pain you won't move your joint, and later leads to there may be immobilization and later leads to a restricted mobility. Another example is after a joint disease or a joint trauma. Again, you are keeping there is a joint inflammation or effusion and there is immobilization. This also leads to prolonged immobilization, later leads to restriction of motion. Or in case of any joint inflammation, or in case of any muscle, tendon or facial disorders of the muscle or tendon or disorders of fascia like a fasciitis or tendinitis or myositis, this also leads to a restricted motion due to prolonged immobilization. Another example is for prolonged immobilization is any skin disorders, maybe a burn or a skin graft or scleroderma. In this condition, you keep most of these condition, there will be chance of a prolonged immobilization and later leads to it causes a restricted motion. Now, after there is an osteophytes or there is an ankylosing spondylitis or any surgical fusion as done, this type of bony block also causes prolonged immobilization of the muscle, later leads to restricted motion. Again, a peripheral lymphedema, any vascular disorders also leads to a prolonged immobilization, later leads to restricted motion. Now, the second cause is a sedentary lifestyle or a habitual faulty or asymmetrical postures. For example, a person is confined to bed or a wheelchair, or any occupation who is doing a prolonged sitting or prolonged lying position, or any work environment as such, a sedentary lifestyle, there will be chance of restricted motion. Now, the third cause is, for example, any neuromuscular disorders is there. For example, it may be a central nervous system disorder or a peripheral nervous system disorder dysfunction. This causes these type of neuromuscular disorders which may cause either spasticity or a rigidity or a flaccidity or a weakness or even a spasm. This causes what is happening, there will be chance of paralysis, there may be tonal abnormalities, there may be muscle imbalance, and this also leads to a restricted range of motion. Now, there are some postural malalignment. It may be congenital malalignment or a acquired one. Example is scoliosis, kyphosis, lordosis. These also leads to a restricted range of motion. So these are what we were discussing was the factors which contribute the restricted range of motion. Next side heading is contracture. Contracture can be defined as an adaptive shortening of the muscle tendon unit and other soft tissue that crosses or surround a joint that result in a significant resistance to passive or active stretch and may limit the range of motion, which may be compromise the functional abilities. This is the exact definition of contracture. It's an adaptive shortening. Adaptive shortening, and so that it restricts the motion, range of motion, and compromise the functional abilities, is known as contracture. Now, there are different types of contracture. It may be a myostatic contracture, it may be a pseudomyostatic contracture, it may be an arthrogenic or periarticular contracture, it may be fibrotic and irreversible contracture. What is myostatic contracture? Here, what is happening is that there will be a reduction in the number of sarcomere unit in a series. So, there is no decrease in the individual sarcomere length, but there is no significant loss of range of motion. So, this is called myostatic contracture. Next type of contracture is the pseudomyostatic. It gives rise, what is happening is that there will be change in the tone of the muscle. It seems like a myostatic contracture, but there is no myostatic, actually there is a change in the tone, like seen hypertonicity associated with CNS lesion, like CVA, spinal cord injury, traumatic brain injury. So there will be a pseudomyostatic, there is no contracture is there, but there is a hypertonicity is there, and muscle spasm or guarding may also there. Now, arthrogenic and periarticular contractures. Any intra-articular pathology, like due to any intra-articular pathology, adhesion, synovial proliferation, joint effusion, or irregularities in the articular cartilage, or any osteophytic formation, this may cause a contracture in the joint or around the muscle, around the joint. This is called arthrogenic contracture. And periarticular contracture means when a connective tissue that crosses and attaches the joint restrict the motion, it is known as periarticular contracture. Now, next is fibrotic contracture. That is due to any fibrotic changes in the connective tissue of the muscle and periarticular structure. This is called fibrotic contracture. That is, tissue, elastic tissue may be converted into a fibrotic tissue. This is called fibrotic contracture. Now, we discussed mobility or proper flexibility is important. Why it is important is that it improves the performance, it decreases the chance of injury, and there are lots of other benefits of the proper mobility. So, there are lots of techniques which improves the mobility. So, the most and the important technique is the stretching. There is other neuromuscular facilitation techniques are there, There are muscle energy techniques are there are joint mobilization and manipulation. These are the other techniques to improve the flexibility. Now, among all these techniques, the first and the foremost is, the most important technique is the stretching. So, what are the indication for the use of stretching? When we can use stretching? Stretching can be used, there are certain conditions. If the range of motion is limited because of soft tissue have lost their extensibility as a result of adhesion or a contracture or a scar tissue formation causing functional limitation or disabilities. This is the first indication for stretching. So, range of motion might have limited because of this contracture, because of this adhesion or due to a scar tissue formation, and this causes a functional limitation. So, you can go for stretching. Now, if the restricted motion, first of all there may be a chance of functional limitation or disability, or if the restricted motion may lead to a structural deformities, in this case, if you are feeling that stretching can prevent this structural deformities, you can go for stretching techniques. Now, usually if there is a muscle weakness and there will be chance of a shortening of the opposite muscle. For example, if the extensors of the wrist are weak, the flexors may get contracted and my hand will be in this position. So, in the one muscle weakness causes opposite muscle to be tightened or shortened. So, in this condition, you can go for stretching techniques. So, a muscle weakness which causing a shortening of the opposing muscle tissue, you can go for stretching. Now, we already discussed that stretching, that flexibility is having lots of benefits, like it decreases the chance of injury, it improves the performance, etc. Like a shock absorbing mechanism in a car, it decreases the chance of injury. So, you can add stretching techniques in regular fitness program for the prevention of, especially among the players, for the prevention of injuries. So, it can be used as a part of total fitness program designed to prevent the musculoskeletal injuries. Now, it may be used prior to and after vigorous exercise, potentially to minimize post-exercise muscle soreness. That was another benefit we already discussed because of stretching, that it decreases the chance of DOMS or post-exercise muscle soreness. So, you can give for, before doing a vigorous exercise program, before doing a vigorous training program, you can go for a stretching session along with the warm-up session, so that it can prevent the post-exercise muscle soreness and DOMS also. Now, what are the contraindications? So, we discussed the indications of stretching. So, there are some contraindications to the stretching. For example, if any bony block is there, which limits the range of motion, so there is no benefit of stretching. You should not go for stretching, because stretching does not have any benefit there. Now, another condition, there is a recent fracture and proper bony union is not done yet. So, there was a recent fracture and there is no proper bony union is not there. Bony union is incomplete. Do not go for stretching. It is a contraindication for stretching. So, this has to be, in this case, we have to avoid stretching. Now, next is, if there is an acute inflammatory process is there, there is heat is there is swelling is there, or soft tissue healing, so there will be a healing process also. So, if you are doing this stretching to these structures after during an acute inflammation or acute inflammation, what will happen is that it will decrease the chance of healing. Now, once you have started your stretching techniques, you feel that there is a severe pain, sharp acute pain starts with the joint movement or muscle elongation. You should stop stretching. It's a contraindication. Now, there is a hematoma is there. or other any indications of tissue trauma is there, you should not go for stretching. If already a hypermobility is there, if already hypermobility exists, you should not go for stretching. And if the short and soft tissue provide necessary joint stability, for example, in certain conditions where there is a shortened tissue can give a better stability or a better neuromuscular control. In that case, you should not go for stretching. Now, a person with paralysis and weakness, this short and soft tissue enables a patient with paralysis or severe muscle weakness to perform certain functional skill. Otherwise, it is not possible. In that condition, you should not go for stretching, and you should not do stretching in these conditions. So, these are the contraindications for stretching. Now, there is another term called selective stretching. Now, here in selective stretching means you are going to apply stretching selectively to a selective muscle group. For example, you are allowing the limitation of the motion of fingers flexors. For example, your finger flexor there is a limitation of the motion of the finger flexor in a paralyzed patient, and or in a spinal cord injury patient. You can leave that finger flexors and you can go for wrist stretching. So, selective stretching means it is the process whereby overall function of a patient may be improved by applying stretching technique selectively to some muscles and joints, but allowing the limitation of motion to other joints, so that he can do some functional activities. So, selective stretching means we are stretching selectively to certain muscles. Now, hypermobility. The next term we are going to define is the hypermobility. Hypermobility means there is an increased mobility. The joint movement and the muscular movement is increased. This condition is known as hypermobility. Now, we will go through the different types of stretching techniques. There are different types of stretching techniques are available. The first one is static stretching. Next is cyclic or intermittent stretching. If we are keeping stretching for a prolonged period of time, this is known as static stretching. Next type of stretching is the cyclic or intermittent stretching. Here in this case, we are stretching for a shorter period of time and you are removing the stretching force. Again you are giving the stretching. This is called cyclic stretching or intermittent stretching. Third type of stretching is the ballistic stretching. Ballistic stretching means you are giving a fast stretching force and you are removing the force. This is known as ballistic type of stretching. Next type of stretching is the PNF stretching. That is, here we are including the PNF, that is proprioceptive neuromuscular facilitation stretching program. You are incorporating the program, this functional movements, we can say a functional movements along with the stretching. Then next one is the manual stretching. Here we are using the manual force for the stretching techniques. And next one is the mechanical stretching. Here manual stretching means you are using the trainer or therapist does the stretching. Then the mechanical stretching, we are using any mechanical instruments. We are incorporating any instrument for stretching that is known as mechanical stretching. Now the next type of stretching is the self-stretching. Self-stretching means the person stretch himself. That is by using, if the person stretches himself, this is known as self-stretching. Now the other type of stretching is active stretching and passive stretching. Passive stretching, we can say it as a manual stretching or a mechanical stretching, and active stretching it is actually a self-stretching technique. Now, what are the determinants of stretching intervention? First one is alignment. That is, the alignment of the limb is important. That is, alignment with the positioning a limb or a body such that stretch force is directed to the appropriate muscle group. This is called alignment. Next one is the stabilization. Stabilization means the fixation of one site of attachment of the muscle as the stretch force is applied to the other bony attachment. So, usually a muscle will be having two attachments, that is a proximal and a distal attachment. Here you are stabilizing or fixing one part of attachment and you are moving the other attachment. This is called stabilization. So that the proper stretching can be done. Next one is the intensity of stretch. That is, intensity of the stretch means how much magnitude the stretch force you are applying. That is, whether how much force you are applying, and this means the intensity of stretch. Then next one is duration of the stretch. For how much time you are giving a stretch. That is, length of the time the stretch force is applied during a stretch cycle. That is, if you are giving for 1 minute, if you are giving it for 10 minutes, or if you are giving for 5 minutes, this means the duration of the stretch. Next is the speed of stretch. That is, speed of stretch means speed of initial application of the stretch force. The next is the frequency of stretch. That is, how many number of stretching session you will be doing per week or per day. This is known as the frequency of stretch. If you are doing it twice, or if you are doing it thrice, if you are doing it 10 times, this means the intensity of stretch. Next is the mode of stretch. What type of stretch you are doing? Whether it is a static stretch depends upon what manner of stretch. That is, whether what type of force you are using. That is, if you are using what type of stretch force, that is, whether it is a static, whether it is a ballistic, whether it is a cyclic type of force you are using. Or the degree of patient participation. That depends upon patient participation, either whether it is a passive stretch, whether it is an active stretch, whether it is an assisted stretch. Or the source of stretch. That is, either it is a manual stretch or a mechanical stretch, or it is a self stretch. So these are the determinants of stretching intervention. So in this session we already discussed about what is flexibility, what are the importance of flexibility, what are the benefits of flexibility, what is meant by contracture, and what are the indication, contraindication, in which condition you can give the stretching. There are some references, you can go through the references. Thank you. Now we will go through the tracts of the spinal cord. Now I told you there are two types of tracts are there, ascending tracts and descending tracts. The sensory information from the receptors throughout the most of the body is relayed to the brain by means of ascending tracts fibers that conducts the impulses up to the spinal cord. So from outside the body, the sensory information, once it reaches the spinal cord, it passed through these ascending tracts and reaches the brain. When the brain directs the motor activities, these directions from the central nervous system or brain, it forms the nerve impulses and travel down through the spinal cord through the tracts only. So travels down the spinal cord through the descending tracts. Ascending tracts are the tracts which carry signals in the spinal cord. Typically, types of neurons are available in the ascending tracts. The first order, there are first order neuron, there are second order neuron, there are third order neuron. First order neuron, it detects the stimulus and carries into the spinal cord. So first there are first order neuron, it detects the stimulus and carries into the spinal cord. Second order neuron is seen within the spinal cord. It is continuous to the thalamus, to the sensory, that is, thalamus is the sensory relay station. So second order neuron in the spinal cord carries to the thalamus. Then third order neuron, it carries signals from thalamus to the sensory region of the cerebral cortex. So once you say the ascending tracts, the prefix will be spino. For example, the spinothalamic tract or spinoreticular tracts, spinocerebellar tracts. The tracts which prefix spino means these are the ascending tracts. So, it is having 3 neurons, a first order neuron that is detect the impulse and carries impulse stimulus and carries to the spinal cord. Second order neuron, it is in the spinal cord and it reaches till the thalamus, and a third order neuron which carries signal from thalamus to the sensory region of the cerebral cortex. Now, which are the ascending tracts? These are dorsal column tract, spinothalamic tract, spinoreticular tract, and spinocerebellar tracts are the ascending tracts. So, dorsal column tract, dorsal spinothalamic tract, spinoreticular tract, and spinocerebellar tracts are the descending tracts, ascending tracts. Then descending tracts are the motor tracts. These are pyramidal tracts. These can be divided into pyramidal tracts and extrapyramidal tract. Pyramidal tract include lateral corticospinal and anterior corticospinal tract. Then extrapyramidal tract includes rubrospinal tract, reticulospinal tract, olivospinal tract, and vestibulospinal tract. So, we were discussing about the ascending tracts. The first ascending tract is the dorsal column tract. Dorsal column tract is a tract which carries sensations related to the discriminative touch, visceral pain, vibration, and proprioception. Discriminative touch, visceral pain, vibration, and proprioception is carried through dorsal column tract to the brain. Now, it is having again 3 neurons, the first order neuron. First order neuron, it detects the stimulus. There is fasciculus gracilis and fasciculus cuneatus is there. Fasciculus gracilis carries sensation from below T6 and fasciculus cuneatus carries sensation from T6 or higher level. And there is second order neuron. It synapses with the first order neuron in the medulla and it deposits. Then the third order, it travels up, and the third order neuron synapses with the second order neuron at the thalamus and carries signals to the cerebral cortex, that is at the post-central gyrus. The system, it is a contralateral system. So, this is the dorsal column tract. It is a tract which carries sensation of discriminative touch, visceral pain, proprioception, and vibration. Next type of ascending tract is the spinothalamic tract or spinothalamic pathway. Now, spinothalamic pathway is the pathway or tract which carries sensation of pain, pressure, temperature, light touch, tickle, and itch. It is located in the anterior and lateral columns. Then deposition of the second order neuron occurs in the spinal cord, and third order neuron arrives again at the thalamus level and continue to the cerebral cortex of the post-central gyrus. So, second, the ascending tract is the spinothalamic tract. Next, we have the spinoreticular tract, especially it carries the pain signal from a tissue injury site. So, the deposit in the spinal cord and ascend with the spinothalamic fibers and end with reticular formation. Third and fourth order neurons are it continue to the thalamus and cerebral cortex. So, there are third and fourth order neurons are present in the spinoreticular tract. Next ascending tract is the spinocerebellar tract. In the spinocerebellar tract, the first order neuron originate in the muscles and tendon. The second order neuron ascend in the ipsilateral lateral column, and it terminate in the cerebellum and it transmit proprioceptive signals from the limbs and the trunk. So, spinocerebellar tracts for the transmission of proprioceptive signals from the limbs and trunk. So, these were the ascending tracts or the sensory tracts. Now, there are descending tracts, especially motor tracts. So, there are two types of descending tracts are there. These are a direct pathway and indirect pathway. Direct pathway, that is called pyramidal tract, and indirect pathway, it is called extrapyramidal tract. Now, this motor pathway or descending tracts include two types of neuron. There is upper motor neuron and the lower motor neuron. Upper motor neuron begins with the soma in the cerebral cortex or brainstem, and lower motor neuron that is in the soma in the anterior horn axon leads to the muscle. Now, we can divide the tracts into two types, the descending tracts into two types, that is pyramidal tracts or pyramidal system. It is also called corticospinal tracts, and an extrapyramidal system. Now, we will discuss about the pyramidal system or corticospinal tract. These are the direct system, direct pathways which originate from the pyramidal neurons in the percental gyri in the brain. Now, pyramidal neuron is in the upper motor neuron, and it forms the corticospinal tracts. The upper motor neuron synapses in the anterior horn with the lower motor neuron. Then this lower motor neuron activates the skeletal muscles. This direct pathway regulates fast and fine skill movements. That is, this fast movement and skilled movement is directed by the pyramidal tract. Now, there are two types of pyramidal tracts are there. There are two parts are there. There is a lateral corticospinal tract and anterior corticospinal tract. In lateral corticospinal tract, upper motor neuron deposits in the pyramids of the medulla, and in the anterior corticospinal tract, upper motor neuron deposits at the spinal cord level. Now, there are some other descending system other than the pyramidal system. These are called extrapyramidal system. Now, its upper motor neuron originates in nuclei deep in the cerebrum, and upper motor neuron does not pass through the pyramids, and lower motor neuron is in the anterior horn of the motor neuron. It is at the lower motor neuron is an anterior horn motor neuron, and this system includes the indirect system or extrapyramidal system includes rubrospinal tract, vestibulospinal tract, reticulospinal tract, and tectospinal tract. So, these are not like pyramidal system. This in the extrapyramidal system is multisynaptic. Now, the different extrapyramidal system we already named it: tectospinal tract, reticulospinal tract, vestibulospinal tracts, and rubrospinal tract. Tectospinal tract, the reflex, it produces the reflex turning of the head in response to the sight and sound. Reticulospinal tract, its function is it controls the limb movement. Important to maintain the it is important to maintain the posture and balance. So, reticulospinal tract controls the limb movements. So, it's important to maintain the posture and balance. Next is the vestibulospinal tract, that is especially its main function is postural muscle activity that is controlled. And rubrospinal tract, it originates from the red nucleus of the midbrain, and it controls the flexor muscles. Now, we will be discussing about the spinal nerves. So, we already discussed is that spinal nerve is a part of the peripheral nervous system. There are 31 pairs of the spinal nerve, that is 8 at the cervical level, 12 at the thoracic level, 5 at lumbar level, 5 at sacral level, and 1 at coccygeal level. Now, how the spinal nerves are formed? Each spinal nerve is formed by the union of the anterior and posterior roots in the intervertebral foramen. Now, the anterior root, it contains the motor fibers for the skeletal muscle. Those from the T1 to So, anterior root, it contains the motor fibers for the skeletal muscle. Those from T1 to L2 contain sympathetic fibers. S2 and S4 contain parasympathetic fibers. Posterior root contains the sensory fibers whose cell bodies are in the spinal ganglion. So, it is formed from the posterior and anterior root. The spinal nerves are formed from anterior and posterior root. Now, once we see the functional component, we can see there are 4 functional components are there for the spinal nerves. There is a somatic efferent nerve fiber is there. There is a visceral efferent nerve fiber is there. Somatic efferent nerve fiber is there, and visceral afferent nerve fiber is there. Somatic efferent nerve fiber is the fibers that transmit motor impulse from spinal cord to the skeletal muscle. Visceral efferent nerve fiber is fiber that transmit the motor impulse from spinal cord to the smooth muscle, cardiac muscle or glands. These are the visceral efferent nerve fiber. So, afferent is just opposite of that. That is, somatic afferent nerve fiber means the fibers that transmit exteroceptive and proprioceptive impulse, that is sensory impulse from body to the spinal cord. Visceral means the fibers that transmit impulses from viscera to the spinal cord. So, functionally it is having 4 components. Functionally a spinal nerve is having 4 components. These are the somatic efferent, visceral efferent, somatic afferent, visceral afferent. Now, what is a nerve plexus? We might have heard lots regarding the nerve plexus, like brachial plexus, like lumbar plexus, like cervical plexus. What is meant by nerve plexus? It is a complex interwoven network of the nerve. It is called nerve plexus. 3 large plexus are seen at the body. These are cervical plexus, brachial plexus and lumbosacral plexus. The lumbosacral plexus can be further divided into lumbar plexus, sacral plexus. So, nerve plexus means these are complex interwoven nerves. So, mainly 3 types of plexus are seen in the body: cervical plexus, brachial plexus and lumbosacral plexus. Now, we might have heard upper motor neuron and lower motor neuron. What is upper motor neuron or lower motor neuron? Upper motor neuron means the motor neurons that originate from the motor region of the cerebral cortex or brain stem and carry the motor information down to the final common pathway. That is, any motor neuron that are not directly responsible for stimulating the targeting muscle is known as upper motor neuron. And the motor neuron which directly responsible for stimulating the target muscle is known as lower motor neuron. So, that is the difference between upper and lower motor neuron. Lower motor neuron means the motor neuron connecting the brainstem and spinal cord to the muscle fiber, bringing the nerve impulses from upper motor neuron to the muscle or from there to the muscle, to the central nervous system. A lower motor neuron axon terminates at the muscle. So, a motor neuron's axon terminates at the muscle, it is called lower motor neuron, and which is not in contact with the effector muscle, it is called upper motor neuron. Now, what is a motor unit? Motor unit can be defined as a single motor neuron and the group of muscle fibers it is innervated. So, all muscle fiber is in a single motor unit consists of the same muscle fiber type. Now, a single motor neuron and the muscle fibers supplied by this motor neuron is considered as a motor unit. Now, we discussed about the spinal cord. It is having lots of functions. So, there are lots of tracts passing through the spinal cord. So, it is having both motor and sensory tracts are passing through. What will happen once the spinal cord may get injured? Usually, the spinal cord may get damaged, usually during any trauma or any diseases or even during road traffic accidents. So, spinal cord injury is causes damage to the spinal cord and which result in loss of function of the spinal cord. So, both motor and may be chance of motor and sensory function may get affected. So, the frequent causes are the trauma and diseases. So, that spinal cord may get damaged, it causes loss of function completely and partially, that is both sensory and motor function may get affected because both motor and sensory pathway passes through the spinal cord. Now, what are the different types of spinal cord paralysis? Depending upon the location and extent of injury, the different forms of paralysis can occur. That is, once there is a spinal cord injury, sometimes it may cause paralysis. So, how much injury is there? What is the location of the injury? Then the paralysis may differ. Monoplegia means paralysis of one limb. Diplegia means paralysis of both upper or lower limbs. Paraplegia means paralysis of both lower limb. Hemiplegia means paralysis of upper limb, torso and lower limb of the one side of the body. So, if the paralysis on one side of the body, it is called hemiplegia. Quadriplegia means paralysis of all four limbs. Now, what will happen? What each will go through, what will happen if there is spinal cord injury at each level. If the injury is at the cervical level, at C1, between C1 and C3, all daily functions, all daily activities must be totally assisted. Breathing will be dependent on ventilator. Motorized wheelchair controlled by sip and puff or chin movement is required at this stage. Now, if the spinal cord injury is at C4 level, all the conditions will be almost same as that of C1 and C3, but breathing gets spared. That is, breathing can be done without a ventilator. Now, if the paralysis is at C5 level, there will be proper good head and neck shoulder movements as well as elbow flexion, but still electrical wheelchair is required and short distance with the support of some person he can move. Movement can be done. Now, if it is at C6 level, wrist extension movement will be good, but assistance needed for dressing, transition of the bed to the chair or car may be needed assistance. If C7 and C8 level is at the C7 and C8, all the hand movement will get spared. All the hand movement will get all hand movements and ability to dress, eat, drive, do transfer and do upper body washes. Now, if the paralysis at the thoracic level, that is even if at T1 and to T4, normal communication skills may be there. Help may only be needed for heavy that is loading wheelchair into a car, etc. If it is T5 to T9, manual wheelchair can be done for everyday daily living and independent for personal care. And if it is at T10 to L1, partial paralysis of the lower body will be there. If it is between L2 and S5, some knee, hip and foot movements with possible slow, difficult walking with the assistance or aids. Only heavy home maintenance and hard cleaning will need assistance. Now the spinal cord injury, these we were discussing about the complete injuries, complete cut. Spinal cord injury may be complete or incomplete. So, spinal cord syndrome can be classified either a complete or incomplete categories. Complete is characterized by complete loss of motor and sensory function below the level of traumatic lesion. Incomplete is characterized by different neurological findings, that is partial loss of sensor, partial loss of motor function below the lesion. So, injury may be, the spinal cord injury may be partial or complete. So, complete means all the motor function and sensory function will be below the level get affected, but incomplete some functions will be spared, and there will be partial loss of sensory or motor functions. Now, central will partial lesion, we will go through some partial lesion. So, first one is a central cord lesion, usually involves in the cervical region. It usually results from the cervical hyperextension causing an ischemic injury to the central part of the cord. So, central part of the cord get affected. So, there will be motor weakness is present in the upper limb than lower limb. So, as the central cord is get affected, in the central cord syndrome, there will be motor weakness will be more in the upper limb than the lower limb. Then patient more likely to lose the pain and temperature sensation than the proprioception. Patient may complain of burning feeling in the upper limbs, and more commonly seen in older patients with cervical arthritis and narrowing of the spinal cord. So, central cord syndrome means the center part will get affected. So, usually there will be upper limb will be affected than lower limb, and patients may complain of burning feeling in the upper limb, and they may lose pain and temperature, but proprioception may get spared. Next type of lesion is the Brown-Séquard lesion. In Brown-Séquard lesion, one side of the spinal cord, one half of the spinal cord may get affected. That is, Brown-Séquard syndrome may result from an injury only to only half of the spinal cord and is most noticed in cervical region again. Is usually a tumor or a trauma or inflammation may cause Brown-Séquard syndrome. So, there will be motor loss is evident on the same side as the injury to the spinal cord. Sensory loss is evident on the opposite side, especially on the opposite side of the location. Then bowel and bladder will be normal. Person is normally able to walk through some bracing or a stability device may be required. The next one is the anterior spinal cord syndrome. It is usually result from a compression of the artery that runs along in front of the spinal cord. So, compression of the spinal cord may form maybe from a bone fragment or a large herniation. Even a bone fragment or a disc herniation may cause compression of the anterior spinal cord syndrome. Patient with anterior spinal cord syndrome have a variable amount of motor function below the level of injury. Depends upon which area, which which side of the anterior side is get affected. Sensation to the pain and temperature also are lost, while the sensitivity to the vibration and proprioception are preserved. So, these are the different types of the spinal cord paralysis, that is spinal cord injury. It may be a partial injury or a complete injury. That is partial injury is again central cord syndrome is the Brown-Séquard syndrome and anterior spinal cord syndrome. Now, this session we discussed about the anatomy of the spinal cord, and it's regarding the covering, the meninges, and it's part of the meninges. We discussed about the spaces, and we discussed about the cerebrospinal fluid, how it is formed and how it is circulated, and we discussed about how about the anatomy of the spinal cord and regarding the grammaton. Then we discussed about the tracts of the spinal cord, including there are ascending tracts are there and descending tracts are there. Ascending tracts are the sensory tracts and descending tracts are the motor tracts. And there are spinal nerves are there and nerve plexus are there. And that's all.